Assemblymember Stone.
Thank you. Mr. Rogers, you have the unique vantage point of looking at the state level, but also not that long ago at a regional center. And we're getting lots of concern, I know, from all of our constituents about the collapse of that system. And given, as you well know, the entitlement that the Lanterman Act represents and that you have been passionately advocating for and supporting for a long time, I think what would be helpful for this committee, give us just a quick overview of what's at stake, what the risk really is for our ability to deliver those services that is our obligation to the people in this state with disabilities. I mean, people with disabilities are people first and have a right to be supported in the way that the Lanterman Act sets out. But over the years, as we've gone through budget cuts, as we've seen that system change, we've pulled money more and more away from it, leaving them increasingly vulnerable in the communities. Make it real for us. I know we're not going to hear from the public today, but make it real for us. What do you see, what do you know from your experience in the regional center and your view from the state level is in the process of happening, how if we cannot find an adequate and long-term source of funding? I know that's a big question, but give us a sense of it. I think that's one of the things we need to put on the table today.
Well, let me just outline it as a regional center director. We'll go back in time not very long ago, as I've already pointed out. The caseload ratios during the course of time of the reduction in state budget, very significant challenges in state funding. The regional centers were impacted like other social service programs as well. I know that nobody in this room doesn't already know that. As a result, the first impact on our real avenue of service is case management, as I mentioned to you before. And that's one of our missions today, is making sure that regional centers, you understand, is a case management organization established in law, very specifically in law, what some of those roles and activities are of helping with that individual and that individual's family or the individual themselves, a life plan. And that life plan has all kinds of different activities in it, and those activities are addressed by the regional center case management process. They have an individual social worker, and one of the challenges that I'm speaking of now is the ratio of caseload to the individuals has an impact. We have never not said that's one of the major impacts that we have within the regional centers, and as I was director of San Andreas Regional Center. And therefore, the higher caseloads puts more and more challenges on that individual, social worker, as well as the families and in particular the individuals. There are other implications during any of those non-robust state conditions. And one of those, of course, is that the incentive for providers with frozen rates, which we've already talked about publicly, or frozen rates, have not moved in consistency with what's happened in the general economy, especially within the last 3 years. And that is another area that you've already identified. The LAO has already identified as well. All of those issues are targets for a remedy. And many of them require, obviously, more resources. And where are those resources going to come from becomes part of the administration's identification of challenges that we have. And we've been very forthright about what that is. That's why I guess we're sitting here. I would expect that that's why we're sitting here. But it's really it needs to be understood of the complexities of the changes. The majority of our clientele, please understand this, live in their natural home. Over 70% of our clientele live in their natural home. That's a reflection of this act in many ways. Of that fastest growing group, as I already mentioned, are individuals on the autism spectrum eligible under this law. So all of that put together is that they're graduating from their regular special education programs and now are moving towards adulthood. And I'm just identifying that for you so you know we're not trying to have you miss any particular level. And never before have we had this many clientele. And never before we had this many clientele who are adults. And never before those adults are also reaching What is that other age? AARP, as I mentioned before, there's no humor in this, but 50 years of age, 60, 70, 80. So all of that produces other challenge in public policy. Those challenges are attempting to be addressed by the regional centers, and they will always require our resources. That's my best way of explaining it to you in the context that we have before us. So.
Can you update the committee on the status of the Developmental Services Task Force's work and talk a little bit about the goals and progress of the task force and when a proposal based on the work will be submitted, provided?
Thank you, Mr. Chair. John Doyle, Department of Developmental Services. The task force has met several times, and the task force has broken into two sub-work groups. One is looking at regional center operations, and the other is looking at rate issues. The rate issue, our system of rates is complex. There's no question about that, and we are looking at what types of proposals might be most effective moving forward. The regional center operations issues, we're hearing from regional centers, from advocates, from consumers about some of the challenges they face as well. We don't expect that we are going to have any recommendations from the task force in the near term. As the LAO mentioned, it's more likely that it will be, if we do come forward with a proposal, it would likely be closer to the 16-17 budget timeline.
Okay, thank you. On the issue of rates, if this committee were to support a 10% rate increase, what does that cost? It's about $270 million?
If for a 10% rate increase in total for provider rates and for regional center operations, that cost would be about $309 million general fund and about $474 million in total.
Do you have some thoughts on what the most effective approach is to a rate increase? Is it an across-the-board 10% rate increase, or are there targets or priorities that would be built in?
I think that, that is something that I'm sure both the Senate and the Assembly will be considering. We've looked at different scenarios as far as costs and trying to target rate increases, but it's probably the type of discussion, it's a policy level issue, I think.
Dr. Wood.
Yeah, I'd just like to point out, I guess, just for information, if you look at a 10% rate increase, that still puts us below where we were. So I'm actually more inclined to look at a reversal of the 10% cut that happened rather than a 10% rate increase. It's just a little math there.
Assemblymember Bonilla.
I just wanted to go back to a comment you made earlier about oversight, increased oversight. Could you elaborate?
Sure. So as we're looking at the potential of adding additional resources into the system, we want to make sure that they're being used most effectively. We have problems in some of the regional centers right now, Kernan Inland regional centers. We have some issues with how the funds are being spent there. So we want to make sure that we're providing adequate oversight of the regional center system and using those resources effectively.
Okay. And when we're talking about, and I appreciate Mr. Wood's comment that we're using the word increase a little freely when there was and there have been so many substantial cuts, and the system is clearly laboring and entering a crisis if we don't contemplate restoration of the cuts. Would you be planning to propose specifics around the issue of what you mean by increased oversight?
It's something that we'll talk about as we go through the process. I don't have a specific proposal for you right now, but we'll have some ideas on how we could increase the oversight.
And hopefully the task force that's mentioned is also perhaps looking at this issue. I don't know that in the short time frame that we have right now, that is something that we're going to adequately be able to fully address. So I'm hoping that we'll be able to structure something that sets in place the framework around the funding issues, but leaves room and flexibility for the task force to do their work in a very comprehensive manner. Because I often find that oversight, it's necessary, we like it, but it's a really important stakeholder process to get it right. Otherwise, we tend to sometimes put the wrong elements in place and then wonder why nothing has changed. And we've seen in government that happen over and over and over. And we burden a system sometimes with good intention. So that's just, I want to see, oversight taking place in the most efficient, effective, and meaningful manner. Not so that we can check a box or correct maybe we want to correct a problem, but we want to make sure it fits for the whole system where there aren't problems as well, because we tend to usually use a very broad brush here when we're talking about adding new levels of oversight and regulation. So just something that I am aware of.
Okay. Assemblymember Baker.
Thank you, and I think our good colleague, Ms. Bonilla, is absolutely correct and very articulate on the point of the need for oversight and to be careful for how we do it. It sounds like there'll be more discussions about it. There's a task force that'll be part of that. We'll be considering it. But can you get in more detail on what are the problems? What, in terms of the weaknesses that you've seen so far in the particular entity that you're identifying, what are some of the either practices you've seen that have not been working well or concerns that you have, so we can go into the conversation with a little more detail?
Hi, Nancy Bargeman, Deputy Director. Thank you. There's, for both two of the regional centers, we do have on special contract language as a result of some of the oversight that was provided during a time period in prior fiscal years. Both had to do with fiscal management, ensuring that they're following the proper requirements for service delivery, ensuring that the provisions within how they're structuring for rates, approving rates, there's a number of things that really needed to be managed. And again, working with them over the last couple of years, we're certainly seeing a significant amount of improvement. With Inland Regional Center, we're still working closely with additional support and oversight with Kern. So again, because of some of the management and oversight during a time period, that we've been able to structure some performance plans and special contract language to be able to help guide them.
And just brief follow-up. Were any of the problems that you were seeing, sounds like they're on the financial side and the contracting side, but any in the quality of services provided to consumers or their safety? I'm trying to think back as far as any specific complaints. Most of the complaints that we received for both the centers had to do with some delivery of service. As far as outcomes of injury or safety to consumers, I don't have any specific examples that come to mind. But certainly anything that has to do on a fiscal side isn't just limited to that. There was concerns from the community, from family members, from service providers as far as what supports and services that they were receiving. So it's not as simple as just fiscal, but on the other hand, fortunately, there's nothing that's really standing out in my mind that was a direct safety risk for individuals. That's good to hear. And what can you give a sense of the volume of complaints that you experienced?
I'd want to make sure that I get that correct, so I don't have that readily available, but we can certainly get back to you with a summary if needed.
Thank you.
I want to thank all the presenters on this panel. Thank you for your input. We're ready to go to our next panel, which is Medi-Cal Overview Panel. We have Felix Su, Senior Fiscal and Policy Analyst, Health and Human Services, Legislative Analyst Office. Mike Wilkening, Undersecretary, Health and Human Services Agency. Jennifer Kent, Director, and Mary Cantwell, Chief Deputy Director, Department of Healthcare Services. Thank you for being here and welcome. Whenever you're ready, Mr. Sue.
Absolutely. Thank you, Mr. Chair and members. Felix Sue with the LAO. We've been asked today to provide a very brief overview of Medi-Cal. Now, given the sheer size and complexity of the program, our aim will be to give a very high-level structure in terms of how it operates and how it's funded. Basically, just enough background and context to be able to set up some of the main issues that the legislature will be considering during the special session. We were also asked to highlight one of these issues, Medi-Cal provider rates, which we will cover in the second part of the presentation. So starting on page 2 of the handout that is just going around with our overview. Medi-Cal, as most of you know, is California's version of the Medicaid program, which provides healthcare coverage for eligible low-income people. So in terms of who's eligible, it's helpful to think of 3 main categories of enrollees. The first 2 are what you might consider to be our more traditional or long-standing populations in Medi-Cal. 1, families and children, including pregnant women, and 2, seniors and people with qualifying disabilities. The third group of coverage only became eligible in 2014 when the Affordable Care Act provided states with the option to expand their Medicaid programs to cover additional populations. So basically, we're talking about low-income adults who are non-elderly and do not have dependent children or qualifying disabilities. In 1516, this new expanded population is estimated to account for over 2 million enrolled lives in the program. By way of comparison, there are about 2 million seniors and people with disabilities and over 8 million families and children or individuals from the families and children population who are enrolled today. We typically think of Medi-Cal as being a health insurance program in that it pays for medical care. But as we describe on page 3 of the handout, Medi-Cal actually covers a whole slew of services that fall outside the scope of what many consider to be strict medical care. For example, Medi-Cal is actually the state's largest payer of long-term care services, more so than Medicare and certainly more than private insurance. So how are all these benefits actually paid for? The pie chart at the bottom of page 4 of the handout shows that today the federal government is actually the most significant source of funding for the program. It makes up over 65% of the total Medi-Cal spending budget for 1516. This is because Medicaid is a federal matching program. In California, we generally receive a 50-50 match. That is, for every dollar that the state pays towards Medi-Cal benefits, the federal government contributes an additional dollar. For some children who are enrolled with higher income levels, the federal government matches us at a higher rate of 65% of the costs. Finally, for the new expanded population of childless adults, the federal government pays 100% of the costs through the end of 2016. And this higher match ratchets down to 90% by 2020 and thereafter. So going back to 1516, altogether we're talking about $60 billion in federal funding, $18 billion in general fund expenditures, and $14 billion coming from other funding sources outside of the general fund and federal funds. And as this last piece of the pie suggests, there are a variety of sources that states can use to put up the non-federal match for their Medicaid programs, including what are known as healthcare-related taxes. So these are arrangements in which states, including California, tax healthcare providers like hospitals and nursing homes, and they use the revenue to draw down federal matching funds for Medicaid, often with the purpose of, 1, increasing Medicaid payments to the types of providers that are paying the tax, and 2, offsetting other budgetary pressures in their programs. So on page 5 of the handout, we list some of the major examples of healthcare-related taxes in California, including the MCO tax, which is obviously a key topic for the special session and will be discussed in more detail by some of the later speakers today. So having touched on how much spending goes on in Medi-Cal and where that funding comes from, on page 6, we describe how this translates into services actually being provided on a day-to-day basis. So in Medi-Cal, we have 2 main delivery systems, or 2 main models for providing care: fee-for-service and managed care. So in fee-for-service, the state directly pays providers, like doctors and hospitals, for each service or each test or procedure that they render and they bill for. And for that reason, some people informally think of fee-for-service as being sort of the a la carte method of paying for health care. Now, in managed care, the state does not directly deal with healthcare providers. Instead, the state contracts with health plans, or MCOs, to arrange for and pay for all necessary services required by Medi-Cal enrollees. We'll talk a little bit more about that in a minute, but first we want to point out in the graph at the bottom of page 6 that the managed care system has really overtaken fee-for-service in terms of both the number of Medi-Cal lives that are covered as well as the total dollars that are being spent, including general fund dollars. So this doesn't just have ramifications in terms of how we deliver care, but it also has budgetary implications in terms of how the state pays for that care. In fee-for-service, the state is responsible for both setting the level and the structure of how providers get reimbursed. Now, for physician services, the state relies on an itemized rate schedule that, to our understanding, has not been increased over many years, perhaps even over a decade. Now, in contrast, managed care resembles, in some ways, commercial health insurance in that Medi-Cal pays the health plans a fixed monthly rate. We call it a capitated rate, but it's basically like a monthly premium. In return, the health plan assumes total financial risk and responsibility for providing all necessary services, no matter how many services are used, nor what type of services are being used in a given month. Now, where Medi-Cal differs from commercial health insurance is that the premiums or the capitated rates aren't negotiated, at least not in a formal sense. Instead, the state contracts with actuarial firms or an actuarial firm to develop each individual health plan specific rate for a given year. So the actuary does this by analyzing basically a highly summarized form of each health plan's medical claims data to get a sense of what their costs are for providing services in the Medi-Cal program. Now, because this cost data is usually backdated at least a couple of years, the actuary usually also applies a growth trend that's meant to account for medical inflation. So the upshot of all this is that, unlike fee-for-service, where rates for certain services may have been flat for multiple years, managed care plans generally do receive year-over-year rate increases on the level of a couple of percentage points annually, although the situation and the rate structure can differ depending on which plan you're talking about. So skipping ahead to page 9 of the handout, as I said, we were also asked to talk about past budget reductions to Medi-Cal payment rates, as well as which reductions remain in place today, and proposals to both restore and further increase those rates. So the 11-12 budget authorized across-the-board 10% reductions to fee-for-service rates for most providers and services, as well as a corresponding decrease to managed care rates. The cuts were enjoined by the district court through June of 2013. Once the injunctions were lifted, the state had the authority to both proceed with these rate cuts as well as go back and collect the amount of reductions that were owed for the period when the injunction was in place. So that part of it is usually referred to as the retroactive recoupment or the clawback. So the legislation that authorizes the reductions, AB 97, also allows the administration to exempt providers and services from both the clawback and the ongoing reductions to ensure that the state complies with federal Medicaid access requirements. Now, for some providers and services, the administration has taken steps to grant one or both types of exemptions. So quickly, the table on page 10 shows the status of which ongoing reductions and clawbacks were still in place as of the May revise, as well as the associated general fund savings estimates. So as we note on page 11, the assembly version of the budget headed into conference would have repealed all the reductions and recoupments over a 2-year period for an initial cost of $25 million and a full-year implementation cost of $233 million. Now, the final budget that was signed by the governor, it eliminated the cuts for dental providers at a cost to the state of $30 million general fund ongoing. Finally, on the last 2 pages of the handout, we discuss SB 243, which was introduced this session alongside initially AB 366 as parallel legislation in the Assembly. So this proposal would restore the remaining AB 97 reductions and would require further rate increases on top of that baseline of restorations. For example, it would raise inpatient fee-for-service rates for hospital services, which were not initially subject to the AB 97 reductions, and it would also raise the fee-for-service rates for other services to Medicare levels and require a corresponding increase in managed care rates. So altogether, the Appropriation Committees estimated that the cost of this proposal would be, on an ongoing basis when fully implemented, $6.6 billion annually. Thank you very much, and I'm happy to take any questions.
Thanks. Well, let's go through all the presenters in the panel first, and then we'll open it up for questions from the committee members.
Jennifer Kent, Department of Healthcare Services. Good morning. I think as the LAO has done a really nice job of explaining the complexity of a program that now serves almost a third of the state's population, I want to just highlight a couple of issues that we, I think are here today to discuss in some detail is that, we have increasingly moved individuals in our program into managed care for a couple of different reasons. One is that we believe an organized delivery system actually accounts and allows us to have better accountability to the providers and entities that we're contracting with. And then second of all, as noted, is that the fees and rates that we pay our health plans are set in a different way, and they are not necessarily tied to our fee-for-service delivery system. And so when we talk about how we set rates with the plans, it's based on the plan's experience, cost, and utilization within their service area. And that is something that is accounted for every single year, and our actuaries are both required to be able to sign off on those rates as being actuarially appropriate, and then they're further reviewed by the federal government as being actuarially sound. And so I think that is one of the key things that we want to always stress is that we work really hard, obviously, and it's a challenge in a state like ours with the types of geography and challenges in provider access in certain geographic regions, that we really endeavor to make sure that our plans, carrying over 9 million lives over 22 different plans, are being paid in a way that they can try to ensure that the network that they have in place is there to meet the needs. And I know that with the advent of the Affordable Care Act and the amazing enrollment growth that these plans have had, they have had to do more to keep those networks constantly growing in order to keep up with the lives that continue to enroll with us on a monthly basis. So with that, I will stop, and if there's questions, we're happy to take them.
Thank you. Let's continue through the presenters. No more.
We're good.
Okay. All right. So open it up to members of the committee. Assemblymember Thurmond.
Thank you, Mr. Chairman. Thank you to the presenters. Excellent overview. Thank you. Ms. Kent, I wanted to ask you about the last statement you were making about how the actuaries assess, what the real costs are for the health plans. And I guess I want to understand how different what the health care plans receive through Medi-Cal is versus, I guess, how things work commercially. Because if they're, I'm interested in that because we're seeing this trend of hospitals that largely serve communities that are high Medi-Cal closing. And if health plans are being reimbursed essentially for what are their costs, actuarially, determined, why so much movement away from communities that are served by high percentages of residents in Medi-Cal? And I'm speaking from direct experience that in my community we had the primary hospital for 5 cities closed, and I'm thankful to this legislature and to this governor for supporting some resources to help backfill some of those services. But yet it seems that this is a trend, and this is the first time I've heard it described that it's all actuarially determined. So what, are those costs that much different than what health plans are receiving, sort of through their commercial opportunities, or why the trend? Why the trend to move away from communities that have 80% of their patients, like we do, who are Medi-Cal?
Well, so that's a great question, and like everything in Medi-Cal, there's a complicated answer. And so, in this,
can I hit the easy button and get the easy answer?
You can try.
Oh yeah, all right.
But if I don't get it, then you don't.
I know you'll give us a great answer.
So the hospitals contract with our Medi-Cal managed care plans for the patients that the Medi-Cal plans have within them today. In addition, as the LAO paper notes, there is an existing hospital tax on hospitals that has been in place since, I believe, 2008, 2009. There's an interplay there in that, and Mary's going to kick me when I get it wrong because I'm going to try to do the simple version, is that the hospitals agreed to tax themselves, and in doing so, it accounts for both the fee-for-service days in those Medi-Cal patients that they see on the fee-for-service side as well as in the managed care side. The net effect of that tax means that we pay them as a state to the upper payment limit. So there's a federal upper payment limit that hospitals can get under Medicaid, and the tax actually accounts for that, and those hospitals do it either on the managed care through the rates or on the fee-for-service side. And so it's not necessarily as simple to say that you're a plan with a high Medi-Cal population and it must be harder for them to make it because of the offsetting revenues of the hospital tax. It's not necessarily a truism, and in some cases, depending on the hospital, having a higher Medi-Cal percentage means that you receive revenues from the tax that go above and beyond what you would be paid at a Medi-Cal rate. Am I? Okay, good. Okay, so so I'm just wanting to say that it's not just a direct equivalent to say you're a Medi-Cal hospital in a high Medi-Cal area, therefore you must be losing money, because hospital financing is probably one of the most complicated parts of our program, and so it's not an easy equivalent cause and effect dollar amount.
Ms. Cantwell didn't kick you, so I thank you for giving it to us, but you gave us the easier version. But I still am perplexed about why this shift away. And I'm all for increasing Medi-Cal rates. I'm all for restoration. I get it that there's so many needs, but I've heard it stated that many of the systems want to move away from serving folks who are on Medi-Cal. And given the growth in Medi-Cal that was described as part of the Affordable Care Act implementation, we're going to see even more. But it seems that for those providers that do accept Medi-Cal, that it's a guaranteed source of revenue that's based on actuarially determined, based on their actual usage. So I'm having trouble seeing what the loss is and why anybody would move away, and why communities that mostly have low-income folks who are using Medi-Cal are seeing a dramatic trend away from health services in their area.
Well, I think, what we are trying to monitor on a regular basis, and we work with our plans on a constant basis, is the plans are obviously held to the Knox-Keene, standards for network adequacy, and we have a lot of mechanisms in place through our managed care quality metrics and monitoring division, where they are held to certain legal requirements, and then we make sure that they're actually ensuring access. And so it's a complicated topic, but I would say that what you may be hearing is either anecdotal, or it's not necessarily being played out completely by the data that we see. I think that in certain areas, we would absolutely acknowledge it is really difficult to get providers. Up in the far north, rural areas, down in the south, high desert, those are places where it's not just a Medi-Cal problem, it's just a problem, right? There's not, a lot of specialists, there's not a lot of nursing homes, there's not a lot of adult day health centers or anything like that. So I would say, depending on where you are in the part of the state and depending on the sophistication of the provider network, there may be access, there may be more access than we know about. There are places that we're aware where there's not problems, and then there are areas, and we hear from the plans, and I know that there's been a plan that's been profiled in the press recently up in the north, and I believe Assemblymember Wood's area, where there's nursing homes that are just refusing to take patients, and it's a contract dispute between apparently that chain and the plan. And so we are aware of those things, and we follow them closely. We make sure that, if there's a beneficiary impact, we're tracking it. But what we really try to do is make sure that we're using data-specific or specific beneficiary information so that we can go in and see if it's just related to that patient or if it's more indicative of a larger problem in that area.
Thanks. I'll save the questions about how the tax plays into revenue for those hospitals that serve Medi-Cal for later, because I do want to get a little bit more information about that. It's I see it as a key ingredient to the conversation for communities that have high rates of Medi-Cal enrolled folks. I'll save it for our next conversation, and thank you for the information.
Thank you, Assemblymember Thurman. Dr. Wood.
Yes, my question is obviously the rather broad expansion of managed care related to Medi-Cal. Where do you see the future of the fee-for-service part of this going? Because quite, in my experience as a provider was always with fee-for-service. Managed care, quite frankly, didn't really work in the private practice model that I had. So where do you see that going in the future?
I think that we know that there will always be fee-for-service and Medi-Cal for a couple of reasons. And so just on the sheer numbers, I think there's approximately 9 million, a little over 9 million in managed care, and there's approximately 3 million in fee-for-service. Some of those individuals are individuals that have been found to be eligible for Medi-Cal, but they are going through we call it the choice period, in which they're being offered a choice of health plans in their area, and they just haven't made a choice, and they have a certain amount of time in which to make that choice, and so they're just in fee-for-service for a very brief amount of time. There's other individuals, and I believe a significant number of them are for limited scope, emergency-only Medi-Cal, and those are usually individuals that do not have appropriate documentation for immigration status. There are dual eligibles, so individuals with both Medicare and Medicaid. And then there's very small populations of people that we do not mandatorily enroll into managed care today. So foster care is one example where we just don't mandatorily enroll them. But by and large, the rest of the bulk of the population is in managed care. So, we think of 3 million individuals as being the residual, but it's still a large number of people, but those are people that are not most likely ever going to be in managed care by and large, and so the system will always have to continue to exist at some level.
Can you share your view of how rate increases can help provide a solution to access problems that we're having with Californians on the Medi-Cal program, and maybe some reference to the increases that were in this year's budget in the Denti-Cal program?
Sure.
Could help inform that?
Great. So I think I have testified in front of this committee before on rates in particular to dental, is that rate increases and rates are a component of how we both maintain and enhance access and programs, but it's not the only thing. So in the Denti-Cal example, with the recent AB 97 restoration for the dental, what we believe and what we are hoping to come back and report on at a future date in terms of changes that we've made in the program is that we believe that the AB 97 restoration will go a ways in improving and increasing access in the dental program in terms of either keeping the dentists that we have or encouraging dentists to take either more Denti-Cal patients or to join the program for the first time. I think the other things that we believe are important when we talk about maintaining access in addition to rates are administrative simplification. So we look at what we do in terms of how we enroll providers, how many times if we make them enroll, do we make them enroll for each location? We look at our treatment authorization requests. So in the Denti-Cal example in particular, we're looking at why we require dentists to provide copies of x-rays prior to doing certain procedures, and if there's a way to try to remove some of those because they are either no longer necessary or we have different kinds of analytics in our system that we can actually monitor for program integrity reasons. And so I would say, rates broadly are a piece of a very complicated puzzle of how we ensure access. And so as the health plans, as we've seen there, is that because they are not tied to fee-for-service rates, they are able to come up with a variety of different ways to pay providers. And so we don't begin to even know how the 22 plans do it. They can pay those providers on a capitated basis. They can pay them on a fee-for-service basis. They can pay them on a case-by-case, out-of-network basis. And so it's not necessarily that the fee-for-service rate on a plan level just translates. And so when we do increases in Medi-Cal, and those rate increases impact our managed care side, it's not a dollar for dollar, again, because it's on a capitated basis, and so we have to kind of actuarially smooth that out. So what you would maybe see on the fee-for-service side is a straight dollar amount, straight percentage amount. That percentage is usually less on the managed care side because it gets smoothed across an entire population. And so the same to the benefit of the AB 97 reductions when we did those on the plan side. The reduction on a going forward basis was much less, obviously, from an impact standpoint. And the plans themselves decided whether they wanted to pass that rate reduction down to those providers or whether they wanted to use reserves or some of their admin overhead to actually absorb those cuts. And so, again, that's one of the many benefits that we feel managed care is a superior system for how we, provide care to, millions of people.
Thank you. As a follow-up, I note that in the governor's proclamation calling this second special session, there's specific reference to establishing mechanisms so that any additional rate increases expand access to services. Can you help the committee maybe with an example of a mechanism that would ensure that additional rate increases expand access to services, and maybe an example of a rate increase that doesn't expand access to services?
Sure. So when we talk about the specifics around what was mentioned in the proclamation, where we would, if the outcome of this special session is that there are additional revenues identified and secured for a rate increase, we would work within our program to say, what are some of the main places, maybe on a geographical basis, where we really feel that there needs to be some enhancement. And so I know that especially in some of the rural areas and in some of the most urban areas where there's just simply not a lot of specialists, we would probably look, that would be one of the main areas where I would say we would look to say, can we do something to encourage a specialist, an orthopedic surgeon or a neurosurgeon or someone who deals in liver disease or something like that. We would say either to the plans, we would want to know some of the data about if they have difficulty contracting with certain specialists, and then we could obviously look on our fee-for-service basis. Then you would do kind of a geo map to say, are there other neurosurgeons in this area, and do they take Medi-Cal at all? And, we would be able to hopefully be able to target a rate either through a plan or on the fee-for-service basis to encourage those providers to accept Medi-Cal and or increase their Medi-Cal population if they didn't have one, to begin with, or to take more. I think that's what we think about when we try to talk about targeting. I know that in our waiver, we have also indicated that that's one of the areas in the dental area in particular to either incentivize or encourage dentists to join the program or to increase their overall patient mix to increase Medi-Cal participation. So I could see in rate increases, if we just applied a rate increase and we didn't move either the provider to take more Medi-Cal or to join Medi-Cal, that is a rate increase in our mind that doesn't actually accomplish anything. You may be paying that provider more, but it's questionable as to whether they would have continued to do the exact same thing without the rate increase. And so I think that's what we're struggling with, is especially when you have a program that serves 12.5 million people, spends $95 to $96 billion, you can appreciate why we'd want to target money very, very carefully, because spread across a large pool like that, you want to make sure that it actually is impactful.